So thank you for participating in this webinar. Today I'm going to be talking about how to evaluate safety promotion efforts that are done in community settings using the International Safe Community Model. The motivation for this presentation comes from how to evaluate the International Safe Communities WHO initiative. This is a global effort for grassroots-driven interventions at the community level to increase safety. The research questions that one may ask is, how do we know that participation in the network works? Or how does a community know what programs work? The contents of the webinar today will be several. We'll be talking about the importance of evaluating efforts, what to evaluate. We'll talk a little bit about process, impact, and outcome evaluations, a little bit on methodology, on research designs, qualitative and quantitative information, and indicators. And then we'll illustrate this with a proposed way of evaluating the WHO Safe Community Model. So the main purposes of evaluation are to help us decide whether an ongoing program works relative to its goals and objectives, maybe also look at why the program did or did not work relative to planned process, helps us decide also how to restructure the program to make it work or work better, and whether to change future funding for the program. For a particular community, it actually is very helpful to show folks in the community that we are doing good things, show stakeholders that we are doing good things, and also gain a lot of political clout. So why is it valuable to communities? It's helping them to choose priorities, to recognize their successes, maybe learn from their failures, and especially how to save scarce resources and improve the quality of the programs. All of these actions will help us in the sustainability of a particular program. Now the evaluation, when we talk about evaluation, we need to think about a continuous cycle where we may identify a problem and where we're working. We define a target audience. We then identify resources, set goals and objectives, choose strategies. We review those strategies and refine the implementation in what's called formative evaluation. We implement those strategies, and then we go to what's called the formal evaluation aspects of process, impact, and outcome. We disseminate our results, and we continue this process. It is not a single time evaluation, but a continuous process. So I mentioned that there is formative evaluation, which is prior to implementation, and the formal types of evaluation that are done of a program involves process, impact, and outcome. And let me take a few seconds to talk about these particular types of evaluation. When we talk about process evaluation, we're trying to address what was done, how was it implemented, how well was it implemented as planned, and should it be done differently next time? So the types of questions that we are looking at in process evaluation is who carried it out, who was this the appropriate person or group, who supported or opposed the intervention, what methods or activities were used, who participated, were participants involved in the planning, what resources were used, what problems were encountered in administering the intervention. Impact evaluation is now looking at some of the results. And here the results may be have changed people's knowledge or attitudes, beliefs, skills, or behaviors and practices. So in impact evaluation, the types of results and questions that we asked is, did the participants' knowledge, beliefs, and attitudes change? Or was a policy adopted? Or was a policy enforced? Or did behaviors related to injury events change? And I give some examples of some particular types of situations where one would be asking these questions. So these sorts of evaluations of the results of the impact are looking at what we call precursors of the outcome evaluation. And the outcome evaluation is when we're looking at changes in injury events, for example, or in morbidity and mortality, or in the costs of the injuries, whether they're direct and indirect or individual and societal. So the types of things that we're measuring in outcome evaluation is that the intervention reduced the number or rates in a defined population of events such as falls or traffic crashes, injuries, or deaths. So those are the three types of formal evaluation outcomes that we look at. So we talk about process, we talk about impact, and we talk about outcomes. How do we go about obtaining information is the next topic that I would like to cover in this webinar, addressing methodology. So parts of methodology involve where do I get data and how can I successfully use it to produce meaningful answers. One needs to have an understanding of the data sources, how they define injuries, injured individuals or injury events, and how does one use and integrate data for studying injuries. The second part of methodology is how do we actually come up with ways of understanding risks of an event, or what are the study designs and what risk estimates they provide. And then we talk about statistical models for risks. And then finally, how do I know the effect of some action? And this is where evaluation is what we're really doing. So how do we understand the effects, and then what study designs and what effects estimates they provide? As well, we go back to statistical models for risk. So let me start with some examples. Surveillance data is one of the very commonly used and obtainable type of information, and it allows us to study trends over time. I give an example here of a study that was done using surveillance data on the number of deaths of motorcyclists and how does that relate to interventions. And we see here that it's a simple graph where one is plotting over time the number of deaths, and one is identifying different types of activities that were done in the city, and one tries to argue that the changes that are observed in the number of deaths may or may not be related to those activities that were done in the community. It allows us to study descriptively trends over time, but many people argue, how do we really know if something is actually due to that intervention or maybe due to other factors that may be going on? But surveillance data is a very useful way of getting data to study the impact of our interventions in a community. Another example is to get targeted observations that allow us to do what's called a before-after study. This study that I'm illustrating here is from Sweden, where they were looking at the impact in terms, or actually the outcomes in terms of crashes and collisions that took place when they intervened in a particular bridge in Sweden, where there was initially, in the first time, there were just 2 lanes, and cyclists and pedestrians were sharing the lanes, either coming or going. In the second period, the government had made a structural change where the cyclists were separate from the pedestrians, and they wanted to examine whether the effect of this intervention done on this bridge was revealed in terms of the crashes, single crashes and collisions. So they were looking at the period before the intervention and a period after the intervention, and what they noticed was actually that there was a higher rate of crashes and collisions afterwards than before. The reasons for this are some things that they did not measure and led to speculation. In order to be able to get an understanding of potential factors that may be affecting the rates before and after or the trends over time, one usually requires to collect data in what's called research studies. So the third way of getting information on factors that may be related to a particular type of intervention or to a particular type of injury would be to do a research study. So I illustrate here, I don't give the results of them, but one way of doing it that's not too expensive is to do what's called a case control study, where cases, in this example, they looked at fatal residential fires, so residential fires in which there was a fatality, and they took residential fires that they resulted in no fatalities as the controls. And then one looks at the factors that are present in the fatal ones and the factors to see if they're present or not in the non-fatal ones, to be in order to get some relationship on whether that factor is related or not to a residential fire being fatal or not. Those types of studies may tell you about the force of association, but they don't really tell you whether a factor is a causal factor on some injury or some outcome of interest. So what one really requires is what's called an experimental study, where one is controlling all the other factors and one randomizes groups or individuals to a particular type of intervention. This is an example that has recently appeared where they studied in England looking at implementing a fire prevention intervention in what's called a randomized controlled experiment or trial. They had to do it in clusters, and they actually have started this study. They have not shown the results, but this is the type of study that would allow us to study the impact of an intervention done in a community setting to see a causal relationship. Now, research studies are quite expensive. Communities are not able to normally do this. So how do we evaluate a particular community that's participating in the Safe Community project? We may have to rely on ongoing registries and surveillance data in order to do so, and looking at trends and before-after studies. Now, when we're doing that, we face unique issues in injury research. The studies here, when we're studying diseases, other diseases, we don't have the peculiarities that we have in injury injury research. In injury research, we have events that can be considered rare occurrences, where people are not exposed constantly to being an injury victim, because you have to be engaged in a particular activity in order to be at risk for getting injured. There's multidimensionality in the sense that one can have multiple types of events causing multiple types of injuries at multiple types of severities in multiple body parts. So that makes for complexity. There's many covariates or factors that can affect the results. We have events that can recur. Once you've had a crash, you can still, if you haven't died, you're still driving, you can be involved in another crash. And we have competing risks. You may be injured from different mechanisms. Why I mentioned this is that these unique issues lead to complex relationships that make it difficult to understand risks and to evaluate effects. So given this, where does statistics help safety research? Statistics is a science that helps us understand the effects of variability and chance, and helps us, for example, determine how many events to study, how long to study a situation, how to obtain estimates of important parameters. So how many disabled persons in a particular place or in a particular year due to road traffic injuries. It also helps us to summarize quantifiable information, how to describe it, and how to build the evidence of what works. So the tools of statistics are probability theory, and I'm not going to go into that, but I mentioned to you that it helps us to estimate risks and to develop models of the probability distributions of the chance of things occurring. It focuses on associations using the probability models, and it uses mathematics, which is therefore something that I'm not going to go into here. But these help us understand the risks and effects. Why do we want to understand risks? Because it helps us alter our behavior to lower the burden on society. And we study the effects of actions because we want to know the reasons why things are occurring. Reasons matter. As said here in this article, reasons for effects used alone without evidence of effectiveness are unreliable as predictors of the effects of a policy, but reasons matter anyway because they help us explain how. They depict the mechanism through which a policy produces effects. It's easy to find reasons, difficult to find the correct reasons. So we use statistical tools to try to, in observational data, when we're not able to do experimental studies, to try to understand the reasons for the effects of what we're observing. Now, what are the measures of effects that we can use? In these before-after studies and the surveillance data studies, we look at several of these. Most of the time we look at absolute numbers, counts of deaths, for example, as in the Kali study. Differences in occurrence rates at different time points in a before-after study, or ratios of occurrence of rates at different time points. We can look at trends over time, so we can look at absolute changes or just differences, or we can look at relative changes, or since there's multidimensionality of factors, we often do adjusted effects. So we do models that adjust or control for multiple factors. So let's go back now to our Safe Communities model, which is the purpose of this webinar. How do we go to illustrate how we go about doing evaluation studies? Many of you may know that the Safe Communities model is a comprehensive program for the safety of members of communities. But do we know if it is effective? We that participate in it may be convinced, but is the scientific community convinced? And members of the community, are they convinced that the Safe Communities model works? So the questions that we should be asking ourselves is, what research designs are possible to conduct a scientifically valid evaluation? What outcomes are the appropriate ones? And what are the biases in the choice of evaluation approach? So how do we evaluate it? The Safe Community itself has come up with what they call 7 indicators, and the 5th indicator is to assess the program's processes and the effects of change. So they're talking a bit about process evaluation, and the effects of change maybe implies on impacts and on outcome. But what do we evaluate? Do we evaluate each individual's safety promotion activity? Do we evaluate a community's entire program, or a country's safety profile, or even the whole movement of safe community in general? It also says that we should evaluate the programs usually address everybody in the community. So what group should we evaluate? Some programs are for young children, others for adults, others for the elderly, or many of them are for vulnerable groups. We should do everyone, but how can we do this? And how do we get the data? Who provides the data? Do we do sporadic surveys or studies? Do we do ongoing surveillance systems? So the classical approach would be to get the evidence of effectiveness from doing studies and obtain quantitative evidence that favors a hypothesis that the intervention is effective as opposed to a hypothesis that the intervention is not effective. So we have to do either experimental study designs or quasi-experimental study designs, like the before-after studies, or do observational studies like these surveillance data and looking at trends over time. But all of these require these sorts of studies. But communities don't have the resources usually to do these sorts of studies. What communities do is they do activities. And so what I'm proposing, and I'm hoping to convince you in this webinar, is to shift to a new paradigm. Instead of talking about doing our practice and our activities on evidence-based practices, and evidence-based means that you've gotten a study that has shown that it's a valuable thing to do. Can we get evidence of effectiveness from doing things? And I call that evidence of effectiveness from practice. So we can build evidence from two approaches, from qualitative evidence to complement the quantitative evidence. And qualitative one would be a lot of the indicators that the SAFE community wants us to address, like community participation and multi-sectoral collaborations. But we should use quantitative evidence from the practice of activities done by the communities to complement the evidence from studies, if there is any, from that. So we can use soft impact outcomes. The people call them soft because they're difficult to measure, but these are the impact outcomes of perceptions or knowledge, attitudes, and behaviors. We can focus on the hard results outcomes of deaths or societal impacts, or the economical results outcomes that many times we are interested in focusing on. The problem is that if we're going to do effectiveness studies, they require large numbers to be able to show effects and require long time to be able to show effects. And we have the unique particularity in the injury field that for most of the events that we're studying, they are rare occurrences, and many communities are small, so the numbers tend to be rather small. So any individual SAFE community can show impacts on human behavior and perhaps policy, but injuries and deaths are rare enough events that only the largest of cities might be able to show an impact and may still require a long period of time to do so. So a potential solution is to combine numbers from the same community across multiple time periods, or combine numbers from across multiple small communities. Is this possible? Many people argue that it's not, because communities have unique and different circumstances, they have different and varied interventions, and they change over time. So each community also implements a comprehensive and very complex program for the safety of all members of their communities. And they're designated by the International Safe Community Certifying Center for renewable 5-year periods. So how can we work? How can we do something in this case? What study designs are possible to conduct a scientifically valid evaluation? We have to actually have been criticized. One of the processes that is well accepted in the epidemiology and medical field for evaluating the effectiveness of interventions is to combine the results of randomized controlled trials using what's called meta-analysis. There is this Cochrane collaboration that promotes these sorts of activities, and the Cochrane collaboration undertook an evaluation of the safe community model using the meta-analysis approach. However, they decided that the meta-analysis was not appropriate due to the large heterogeneity of the included studies, and they said that they found positive results, but there was no consistent relationship. So using meta-analysis was not something that is going to work to evaluate our studies or our approach. The proposal that we have is using what's called Meta-Regression. And Meta-Regression is where we treat each community's annual efforts as an experimental study and combine the data from various communities over time, accounting for the increase in variability or heterogeneity by using statistical models. And one that we use is called a multi-level regression for meta-analysis, or to make things complicated and sound weird, we call it Meta-Regression. So I'll very quickly mention some statistical technicalities. Those of you that may be interested in looking at more details about it can look at this publication in Translational Behavioral Medicine. We treat each community's annual experience as if it was a different experiment or study in a meta-analysis. We aggregate the individual annual results observed using meta-analysis procedures. We then adjust for the correlation among the data from multiple years of the same community using what's called mixed effects models. And we finally account for increased heterogeneity of the data among communities using meta-regression, which incorporates other community level variables. So let's look at the hypothesis that we're testing. The hypothesis that the Cochrane collaboration tried to test was, the safe community designation have an effect on these communities? And so in statistics, we would have that the null hypothesis is that it has no effect, and we're trying to show that it has some effect. We chose the outcome of motor vehicle-related crashes, deaths, and hospitalizations because that is one that most communities do collect information on. But we're also interested on what are the relative effects of the various components of dynamic interventions. And this is something that the Cochrane collaboration did not attempt to do because they were not even able to address the first question. We are going to try to address both of these questions. So what we did is we combined the evidence from multiple communities and multiple time periods from each community to get the statistical power to be able to show meaningful results. Why we did that? Because there is strength and statistical power in numbers. So we did two studies. We did in 8 communities across this, the globe, from Sweden to Australia, to Sweden to New Zealand, and the US to China. And we got 8 communities, and let me just very quickly go over the results. What we did in our meta-regression was to model what was the effect of getting designated on the crashes, hospitalizations, and death rates in the communities. And what we found was that getting designated led to a reduction in the crash rates of per 100,000 in these 8 communities, and led to a reduction in the hospitalization rate, and led to a very small reduction in the death rate. When we adjust for the time trend, then the reduction is slightly less, but we found that there was an important effect due to getting designated. We wanted to look more at components, and we were able to do that with a second pilot study that we did in Japan. In Japan, we also asked for the same type of minimum simple data on the crashes, the deaths, and the injuries that occurred by year in several communities in Japan, and whether they were designated or not. But thanks to the collaboration with the Japan Institution for Safe Communities, we were able to get more extensive information on the various programs and interventions that they did in the various communities, from coalition building to data infrastructure building to community-based programs, media campaigns, and so forth. So we got information from 8 communities in Japan for 4 years each, and because we got 8 sets of 4 annual observations and communities are quite different, we also proposed to use our meta-analytic approach. So let me show you the results of the Japan pilot study. First of all, let's look at the effect of designation on the annual motor vehicle deaths. And these were small communities, so the number of deaths are very small. On the left side here, we have when they are not designated, and on the right side we have when they're designated. And these boxes are showing us that the middle value of deaths is pretty much the same in both when you're designated or not. So there's not really much difference. What we do notice is that there's less variability after designation. So if I plot here the trajectories or the time trends in death rates for the 8 communities over time, we see that there's, some of these communities are going up, some of them are going down, but what we really wanted to look at is how do these death rates relate to designation status. So if we include the communities that have been designated, we notice with the yellow color are the ones that the years when they're not designated, and the red is when they're designated, and there seems to be maybe a little bit of a trend. Some of these trajectories that don't have a red or yellow ones are communities that have not been designated as of yet. And these are the ones that are actually having the very high increase. When we look at our meta-regression, what we were able to show was that designation or being designated implied a reduction of about 1.6 deaths related to motor vehicles annually. This may seem like a very small amount, and this is a pilot study in communities that have very low death rates due to motor vehicle crashes. It also was not what we would call statistically significant. When we look at motor vehicle hospitalizations, we have now larger numbers. We also see in this what are called box plots that the median or middle value of hospitalization rates before designation and after designation are very similar. There is more variability before than after. But if we look at our meta-regression results, we see that being designated implies a reduction of about 82 motor vehicle hospitalization per 100,000 less. And this is quite impressive because it's also statistically significant, which means that it's likely to be a true value and not due to chance. So this showed us that being designated led to a reduction in motor vehicle related hospitalizations. But what aspects? Designation is just getting named or recognized by an entity outside. But what we were interested in is what particular components of their activities are working or not. So we used the extended information we got in our meta-regression, and the results that we got were that once we take into account the types of activities that they did, we find that designation still continues to be leading to about 80 hospitalizations less per 100,000 per year. And we also find out that media campaigns are quite effective in these communities in Japan. It led to a considerably lesser number of hospitalizations per 100,000, and it's statistically significant. Education programs that were done in children were not at all effective and not statistically significant, so these would not be an important one. So it allows us to find out what components of their activities were likely to be ones that they may want to do. So I know I've taken a lot of time from you, so let me just give you some concluding remarks. That one is that methodology does exist for developing stronger collective evidence for evaluating the effectiveness of multiple community-based dynamic interventions, each using different types of somewhat similar interventions. We can do it with data that is normally collected by most communities, whether it's in motor vehicle-related ones. If a community has the advantage of collecting data on fires or burns or whatever, and we have multiple communities that are doing that, we have shown that we can actually use that information to collectively evaluate the effectiveness of a community-based interventions, even if they are very different interventions using the meta-regression technique. This allows us to develop what I call now practice-based evidence. So evidence that is coming from the practice of the activities that are being done as one way of evaluating the safe community model. I wanted to give you some references and let you know that if you're interested in the statistical methods or want to look more into it, the first two papers go into that. The statistical framework that's going to be used in studies in South Africa has been submitted, and there's a manuscript in preparation for the Japanese study. I'll be glad to address any questions or queries that you may have, and I wanted to thank you for listening from Chapel Hill all the way to the city of Melbourne in Australia. Thank you very much.
Thanks, Rikant.